My name is Maria Papaleontiou. I'm an adult endocrinologist at the University of Michigan, and myself and Dr. Jonklaas will be talking about thyroid hormone therapy today. We kind of split the talk, so I'll talk a little bit about available preparations and dosing, and she'll talk about blood work needed to get and goals of treatment. So when we think about thyroid hormone therapy, and this is, obviously like preaching to the choir, right? But there's different goals that we have to keep in mind, and particularly these three come out, which are stated in the most recent thyroid hypothyroidism guidelines, which are actually almost 10 years old right now. But main goals to provide resolution of the patient's symptoms, and then any signs that are indicative of hypothyroidism, both biological and physiologic markers, to try to achieve normalization of TSH, or, in some thyroid cancer patients where TSH suppression is appropriate, depending on risk stratification, to achieve appropriate goal. And then particularly in our older adult population, which are typically defined as those 65 years and older, to make sure we avoid overtreatment and adverse effects that may have, particularly on the heart and bones. So this is just a schematic showing available thyroid hormone preparations in the United States, and I'm sure most of you are familiar with this chart. But looking at, we have two kinds of synthetic thyroid hormone preparations available: levothyroxine, which is the synthetic T4, and that can come in generic or brand name preparations. We have the synthetic T3, which is liothyronine, or Cytomel, the brand name, and then, desiccated thyroid extracts that have been around for almost a century. And you can see here when we compare the different preparations, the levothyroxine is currently what's recommended as favorable monotherapy in patients with hypothyroidism. We'll talk a little bit more about that later, where T4 actually does get converted in your tissues to T3, which is the shorter acting, more potent thyroid hormone. When you think about our thyroid gland physiologically, that makes 80% T4 and 20% T3, but many thyroid cancer patients obviously do not have a thyroid gland and depend on us to provide that thyroid hormone replacement. T4 does have a longer duration of action, so the half-life is about 7 days, and that is thought to lead to more stable blood levels of the active thyroid hormone levels. But there are some issues with synthetic T4 as well. There's some patients who have been observed to have slightly higher T4 levels than physiologic and lower T3 levels. And there's recently been a survey that was done among several thousands of hypothyroid patients, where about 10 to 15% said they were not satisfied with just thyroid T4 monotherapy, mainly as it related to symptoms and well-being. When we think about synthetic T3, it's a much shorter acting medication. So the onset of action is between 2 to 4 hours. So there's a peak, usually about 2.5 hours. And oftentimes that peak is supraphysiologic. So typically the T3 peak you get is higher than what your thyroid would have normally made. So we do get these marked fluctuations that we can see also in blood work in terms of high peaks and low valleys. The caveats with T3, you do typically need to take it multiple times a day to try to mimic that physiologic action. And we'll talk about that a little bit later. And we typically don't use that as monotherapy, except for thyroid cancer patients who are being prepared to get radioactive iodine. And then both the synthetic T4 and T3 are FDA approved and monitored. Desiccated thyroid extracts, on the other hand, as I said, they've been around for almost a century. It was what existed before synthetic thyroid hormone preparations were made. And these come either from pork or bovine thyroid gland, where they grind up the gland and they add some chemicals to make it, bind it into a pill. And oftentimes they do have fillers and dyes. So I know I have a lot of patients who come asking for natural thyroid hormone therapy, pointing to desiccated thyroid extracts. But to really make it into a pill, they do have to add binders. The main issue with these preparations is that you cannot really adjust the T4 to T3 ratio. So you get grains, these preparations come in grains, and the ratio in those grains is typically about a 4-to-1 in terms of T4 to T3, because this is what's physiologic for a pig or a cow. However, what's physiologic for a human, it's about a 14-to-1 ratio. So typically we get much more T3 than our thyroid gland would have made with these preparations, compared to what the animals need. So this is one of the issues with these preparations. And we can also get a lot of fluctuating serum levels, particularly because this is not, unfortunately, is not FDA monitored. So we can't really be sure whether each grain contains exactly the same amount of T4 and T3. When we think about T4, as you probably all are aware of, there's generic and brand name preparations. And, since the 90s, there's probably more than 40 manufacturers that are making generic levothyroxine. So there's a lot of issues that had come up in the 1990s about what we call bioequivalency. Is each generic tablet the same as the other? Are generics the same as brand name? And I think there's still a little bit of debate about that. Currently the guidelines recommend it's better if patients are maintained on the same formulation if possible. But of course, I've had also many patients who have switched formulations for different reasons. It's important to know that these formulations may have different absorption. And that's why typically the guidelines recommend that if we do switch from one generic to another, because each batch from different manufacturers may contain, not exactly the same dosing, we should check a TSH within 6 to 8 weeks. And similarly, we switch between generic and brand, et cetera. There's the studies that came up out in the early 1990s challenged the bioequivalency, so whether all these tablets are the same. And the FDA actually did respond to those concerns and made the rules tighter, in terms of approving some of these medications, so they're more equivalent. However, we do still recommend checking blood work if we switch. The recent studies, and these are not trials, but these are what we call comparative effectiveness studies, where they compared thousands of people who switch, between different generics or generic and brand name. They have not actually been shown to have a clinically significant effect on TSH. So, clinically, I do still check labs because I do see fluctuations, but some of these studies do not show a difference. The other issue to know is that I do have a handful of patients who have developed hives or allergic reactions when they started taking some of these preparations. And typically that's related to excipients or additives to these tablets. So I have had some success switching some of these patients to the gel capsule. There's also a liquid levothyroxine preparation that's thought to have less of these excipients and better absorbed. The only issue with a gel capsule, we can't fine tune the dose like with a tablet because we can't really cut a capsule in half. So something to think about. So how much? If you're going to start somebody on levothyroxine, or in general, what we learn is that we should think about somewhere between 1.6 to 1.8 micrograms per kilogram. So it was a weight-based dose, and which is typically why we advise our patients, if they have significant weight changes, that we do check thyroid function tests to make sure that the dose they're on is still appropriate. There's some other factors we like to think about. So particularly in older adults, which is one of my focus in both clinic and research, is that we know that actually, even though this is a weight-based dose, a lot of these requirements correlate better with lean body mass. And as we age, we lose lean body mass. So even though when we're older, we absorb levothyroxine less efficiently, we still typically think about these patients requiring anywhere between 20 to 25% less per kilogram than younger patients. And there was a recent study that tried to quantify this and came up with about 1.1 micrograms per kilogram for older patients may be more acceptable. But of course, this depends on absorption. Other things to think about: pregnancy status, women trying to conceive. We know for pregnant women, the levothyroxine requirements go up by 30%. to sustain the fetus until the thyroid gland of the baby starts working. Cardiac disease is another thing we think about. So trying to be more cautious and making adjustments sooner than later to avoid overtreatment. And of course, it depends what TSH you start with. So thyroid cancer patients who had a lobectomy, for example, they may have some residual thyroid function, and they may not need as much thyroid hormone as somebody who had a total thyroidectomy. I always advise my patients that it's okay if you miss a dose to make it up the next day. It's particularly T4 has a long half-life. So as long as your weekly average is the same, it's fine. So if you're traveling, people forget, it's okay to double up the next day. And then let's talk a little bit about absorption. So there's a lot of things that go into thinking about dosing. When you think about levothyroxine itself, there's some things that are not helpful. For example, it degrades quickly with exposure to light, moisture, etc. And only about anywhere between 60 to 80% is really absorbed after you take a pill. So most of the absorption happens within 3 hours of ingestion, and it mainly occurs in the small intestine. So for patients who may have malabsorption issues, patients who had bypass surgery where the small intestine is bypassed, or bowel resection, these patients may require higher doses of thyroid hormone to reach their goal. It's important to know that the maximum absorption occurs when the stomach is empty, and you probably know this, and I'll show some studies as to why in a minute. And it's thought that gastric acidity helps levothyroxine be absorbed. And this is just a demonstration to show you that there's so many things that can interfere with thyroid hormone absorption that could influence what dose you're on or when dose adjustments need to occur. I will typically tell patients to let me know if they're started on medications they think may interfere. A lot of over-the-counter supplements, calcium, iron tablets, etc., can interfere with absorption. And some foods, there's been some study with espresso coffee, etc. There's definitely the ideal way to take your medication, and then there's the real world, life. But this study kind of demonstrates that. So this is a study where they assigned people to take their levothyroxine at different times of day. So this was 65 people. The top panel, you can see BB is before breakfast. So these were people that had an overnight fast, and they took their levothyroxine at least an hour before breakfast. The middle is people who fasted overnight, but then took their levothyroxine within 20 minutes of breakfast. And then the last one is people who took their levothyroxine at bedtime, about 2 hours after their last meal. So you can definitely see that it's much better absorbed on an empty stomach, at least an hour before breakfast. So this is kind of where some of the recommendations stem from when we think about giving levothyroxine on an empty stomach, or if you're going to do it at bedtime, at least 3 hours before your last meal to try to maximize that absorption. In real life, I have patients who say, I'm sorry, but I just have to have my coffee when I get up, and I can't wait the hour. And, I tell them as long as they're consistent and that's what they do every day, I will adjust for that, with the understanding that they may need a higher dose than they normally would have if they didn't take the pill with their dose. And then a couple of other things, calcium supplements, similar findings. And this is just some representative studies. This is a study where patients came for an initial visit. They measured the TSH and free T4 and levothyroxine alone. And then they told them to take calcium with their thyroid hormone, and for 2 months. And then they remeasured the labs, and you can definitely see that there's reduced absorption with the TSH going higher. Similar results after 3 months. Then they asked them to stop the calcium, and then you can see that 2 months after stopping calcium, the levels go back. So things to think about in patients, particularly a lot of my older patients or postmenopausal women who do take calcium. Another medication in postmenopausal women who may be on hormone replacement therapy is estrogen. So similar results, smaller study measuring, levels in both patients who are on thyroid hormone to replace and also in thyroid cancer patients with suppression therapy, about 12 weeks in, where we can see some interference with the thyroid hormone absorption, with recommendation, to measure labs if patients are started on these medications, within 6 to 8 weeks. And then I wanted to put this plug in. This is one of my favorite studies. This is a study that the investigators kind of went out, and I do have patients asking about this. There's a lot of health supplements out there that are over the counter that are not regulated. So for example, you may have seen Thyroid Boost or Thyroid Health and things like that. So these investigators went out and into a supermarket or pharmacy, and they bought 10 over-the-counter supplements, and they measured whether there was any T4 and T3 in them. And you can see 9 out of 10 supplements had T4 and T3. And because these are not regulated, they don't always say that on the label. So it's just to be aware that some of these things may have significant amounts of thyroid hormone. And if you're already taking thyroid hormone, you may be overdoing it if you're adding health supplements. And then the much, heated debate, is there any role for combination therapy? So traditionally, currently, the guidelines do not recommend using desiccated thyroid extracts because of the issues I talked about with the ratio of T4 and T3. And it's actually now on a list from the American Geriatric Society to avoid using in older adults because of risk of overtreatment. However, we do have synthetic T4 and T3, and could we try to replace that 20% T3 that, your thyroid gland was making this way, because we can actually control the ratio. And, this is a much heated debate, and there's still conversations ongoing among the thyroid world. And part of it is, unfortunately, we just don't have enough evidence. So we do need more trials to see whether this is a viable option for some patients. To date, none of the trials that looked at whether this has shown benefit. It unfortunately has not shown any consistent benefit compared to levothyroxine monotherapy, but a lot of these trials were short-term. It's really difficult to mimic physiologic dosing of T3 with the current preparations we have, because you get those high peaks after taking it. So a slow release sustained T3 preparation would be ideal if we were to do this. This is why you have to do it multiple times a day. And typically for my patients who I do try this on, I ask them, it's typically 2 or 3 times a day. And the idea is to try to get those peaks while you're awake, at least, and see if it makes a difference. But there is definitely concern for potential adverse effects because of the higher potency of T3. A couple of years ago, 12 experts from the European Thyroid Association, American Thyroid Association, and British Thyroid Association came together, and they published a consensus on this. And, the main conclusion, if you will, was, well, we need more data to be able to see whether this is something we could recommend. But, particularly the European Thyroid Association said that for selected patients with persistent symptoms who have a TSH where it should be, maybe it could be beneficial for some patients to try this, as long as you're mimicking, what physiologically your thyroid would be making, and as long as you have excluded other things that could be causing those symptoms. So, I do have a lot of patients who come in with fatigue and weight gain, so making sure they don't have sleep apnea, there's no anemia, there's no vitamin deficiencies, etc. There may be a role in using this in the future to mimic normal physiology and maintaining TSH where it needs to be. So what I usually will do in a handful of patients that I will try this is that to set clear expectations up front. I think it's important to communicate with your provider, express your concerns, but also reciprocate and listen to kind of so everybody's on the same page. So it's not a standard therapy, is not currently recommended routinely by any guidelines. And we know there's no evidence showing clinical improvement. So a lot of our evidence is anecdotal from patient report. Discussing with the patients that we still are trying to target, the appropriate TSH to avoid the potential for adverse events. We also have a difficulty, and Dr. Jonklaas will talk a little bit about what blood tests to use because of fluctuation of biochemical levels. So we don't really know how to monitor this very well when we start patients and what's appropriate. And then there may be issues with cost. There's definitely groups of patients I would never try this in, patients who are pregnant, or trying to conceive, because we know that the baby's brain depends on maternal T4 to function. So, and the baby's brain is impermeable to T3. So if you give combination therapy to pregnant women, you may be depriving the baby of thyroid hormone and leading to some neurodevelopmental issues. Patients who have cardiac disease, I always like to be a little bit more cautious. So typically do not consider them for this. And, as you probably know, with your interactions with your own physicians and providers, I think shared decision-making is important. So communicating concerns, feeling like you're listened to, and coming up with a solution that's acceptable to both. Typically, for my patients where I do a trial of this, if there's no improvement in their well-being in about 3 to 6 months, we'll typically discontinue and go back to monotherapy. And how do we do this? This just shows you kind of an idea of if somebody is on just T4, how I would convert somebody to a combination therapy. So we would back off on the T4 dose, and then we would add different amounts of T3, and you can see that's typically taken multiple times a day. So overall, we still consider T4 monotherapy as first line, and we don't have yet enough evidence to recommend combination therapy. But there's a lot of, so there's at least 3 labs I know of in the United States that are trying to create a sustained release T3. And I know there's a lot of effort to try to get some trials up and running to compare different preparations to see if it really makes a difference for a select group of patients. So until those data are out, I think we should be using this judiciously. It's very important to be mindful, for patients who are older. And again, I think communication is really important. So this is what I have. So I'm going to pass it on to Dr. Jonklaas, and then we'll take questions at the end.
All right. So greetings, everyone. My name is Jackie Jonklaas. I'm an adult endocrinologist at Georgetown University. And I'm going to be sort of continuing the story of thyroid hormone therapy by talking a little bit more about monitoring of thyroid hormone. So the topics I'm going to try and cover is, first of all, a little bit about the normal relationship between TSH and free T4, which is something, blood test that you're very familiar with. And then I'll go through what blood tests we use for monitoring in patients with thyroid cancer, a little bit about the theory behind aiming for a low TSH, and what TSH would we actually aim for in different patients, and then how would we adjust our goal for TSH as a patient kind of goes through their thyroid cancer journey. So I'm going to try and go through each of these. And starting with the normal TSH-free T4 relationship. And initially, I'm just talking about what we see in a patient who has an intact thyroid gland. As you know, T4 and T3 are made by the thyroid gland. They act on the pituitary, and then the pituitary makes TSH, which regulates the output of the thyroid gland. So a few things we know about TSH, which sometimes are hard to kind of act on, in general practice, but we do know that different patients may have a different set point for their TSH level. And this slide is simply showing a number of different individuals who had repeated TSH levels checked. And you can see that they had some variation in their TSH, but there was sort of a set point for the TSH which differed between individuals. Another thing that we know about TSH values is that they are affected by patient characteristics such as age and possibly ethnicity and a number of other factors. And this is showing a graph of TSH values and broken out into different age groups. And if you look at this curve in the indicated in the diamonds, that indicates TSH values in older individuals. And so you see that TSH values tend to be shifted a little higher in older individuals. And so that really makes us be mindful of what our TSH goal is in older individuals in whom baseline TSH values might be a little on the higher side. And then again, in a normal thyroid gland, there's a very clear relationship between TSH and free T4. And so if you look at the TSH on the left-hand axis, you can see as the free T4 is higher, the TSH goes down. And we use that as sort of a theory behind our dosage adjustment when we're treating patients with hypothyroidism and thyroid cancer. So what blood tests do we need to monitor individuals with thyroid cancer? So definitely TSH. We usually will measure free T4. T3 is not routinely measured, and obviously there can be a lot of discussion, around that. And then obviously we will also be measuring with most blood tests the thyroglobulin, which is our, cancer marker. And so what we can do with thyroid hormone therapy, you see here a normal TSH reference range going from about 0.4 to 4.5. And depending on what the TSH is in a patient on a dose of thyroid hormone, we can kind of adjust that TSH level by adjusting the thyroid hormone level. And this is just a study which very nicely shows how adjusting a dose can affect TSH. So if you look at the center of that figure where it says optimum, those are patients on a particular dose of thyroid hormone and their TSH is falling within the normal range. On the left-hand side, you see if you reduce the patient's dose by 25 micrograms or 50 micrograms, the TSH goes up. And on the right-hand side, we see that if we increase the dose by 25, 50, or 75 micrograms, the TSH goes up. And that's the principle that we use when we're adjusting doses in people who are taking thyroid hormone. So we've talked a little bit about lower TSH levels as our goal for patients with thyroid cancer. So what's the idea behind this? So in general, we will keep the TSH lower in patients with thyroid cancer than we would in patients with simple hypothyroidism. And again, you see the normal pituitary thyroid axis on the left of this figure. On the right-hand side, you see someone who's had a thyroidectomy, and instead of thyroid hormone from the thyroid gland, you see those two pills, which are representing the thyroid hormone that's being given to the patient, which acts on the pituitary. And so what we try and do is make that dose a little bit on the higher side, depending on the patient's, specifics of their thyroid cancer. And the goal is to make the TSH output from the pituitary a little bit lower. So if there's any microscopic thyroid cancer cells left behind, there's no TSH or less TSH to stimulate them. So that's kind of the theory behind us lowering the TSH. And so this is just a diagram showing all the different doses of levothyroxine that we have available to us. And so we can alter the TSH by altering the dose. And increasing the dose will lower the TSH, lowering the dose will increase the TSH. And so for different patients, we might aim for different TSH levels. And again, you see the normal TSH reference interval here, and increasing the dose, we could make a patient's TSH go from the upper end of the range to 2.5, or from 2.5 to the lower end of the range. And again, what our goal would be would depend on the individual patient. So just a little bit of what we know about TSH suppression. So in general, TSH suppression, and again, that's a low or low normal TSH, depending on how low we push the TSH, is generally associated with improved survival and less recurrence, but not in all studies. So different studies show different results. I think what we're learning is that there's really no benefit of going for a very low TSH in someone who has a very low risk thyroid cancer, who's probably already going to do well. With the higher risk cancers, some studies show that additional suppression of the TSH may improve outcomes. But just again, not all studies show benefit. And again, we're learning more about the sort of risk-benefit ratio as we kind of gather more data. So what are these TSH goals that we've been talking about, for different risk levels of thyroid cancer? So this is now from the 2016 American Thyroid Association guidelines for management of differentiated thyroid cancer. We are expecting a new set of guidelines sometime next year. And so these recommendations may well, change. But in 2016, what the authors of the guidelines recommended was for low-risk patients, we should aim for a low normal TSH, so 0.5 to 2, which is a lower end of the normal range. That if there are patients who've not necessarily had a clear response to their therapy, that we may aim for a slightly lower TSH. And then individuals who have more of an intermediate risk thyroid cancer, we may also aim for a TSH that's a little bit below the reference range. And then patients who have a higher risk cancer, we may aim to push the TSH down even a little bit more. And so based on the recommendations from these guidelines, someone who's low risk, again, low normal or normal TSH, but the lower half of the range, sort of intermediate response, we're maybe aiming a little bit lower. Then for people with intermediate risk thyroid cancer, again, a little bit below the normal range. And for a higher risk patient, an even lower TSH. So that's really talking about sort of initial management when someone's kind of in the early stages of their treatment after their initial therapy has been completed. But what do we do over time? Because obviously someone's risk for recurrence, changes over time. So we don't, keep a static, management strategy. So in general, as someone has a more extended disease-free follow-up, so in other words, they're doing well, we would consider reducing the aggressiveness of the TSH suppression, meaning we wouldn't aim for such a low TSH. Also, if there's a risk of the TSH suppression, so say someone has cardiac arrhythmias, we try and balance the risks and the benefits. And as a patient is followed over time and their sort of risk re-stratification shows that they have a reduced risk of recurrence, we're going to change that TSH goal and aim for a lower degree of TSH suppression. And a lot of the studies that we have about this are not necessarily very rigorous studies. They're sort of observational studies or retrospective studies. So we do need, better data, about this. And so this is a little bit of a complex figure, but what you see on the left is risk of the levothyroxine therapy, moderate risk, high risk, no risk. And then what you see on the row on the top of this figure is the patient's response to therapy. And so if we look at the second from left column, you see if someone's had complete response to therapy and they're at high risk from over treating them with their thyroid hormone, we would not use TSH suppression. But if you look on the extreme right-hand side column, if you have someone who's had an incomplete response to their therapy, and they're at no risk of side effects from the levothyroxine therapy, we might use moderate or complete TSH suppression. And this figure is showing essentially the same thing, but showing us some of the characteristics that may make a patient at increased risk from the TSH suppression. So if individuals have issues with bone density or cardiac arrhythmias, or if they fall into older age groups, those are all things that may put them at increased risk of the TSH suppression. So whenever we're thinking about what TSH goal we should have in an individual patient, we're very cognizant, of the risks also. So we mentioned atrial arrhythmias, and the other one is decreased bone density. And so just by way of illustration, if we have an older individual, who's fallen and fractured and their thyroid cancer has had no indication of any recurrence, we would not put them at risk from TSH suppression. We would maintain a normal TSH. So clearly there are risks of TSH suppression. We believe that there are benefits, but what we need to do is look at each individual patient and determine what the balance of those risks versus benefits are. Then as we continue to monitor a patient, we have to keep checking the TSH. We alter the doses as needed. And we monitor the TSH. And as was alluded to in the last talk, there are many different things that can affect how the dose of thyroid hormone that we give is reflected in terms of thyroid hormone levels and TSH. So we do need to talk to a patient about what are the medications they're on, whether they have new medical conditions that might affect thyroid hormone absorption. And so part of monitoring a patient is ongoing, surveillance for other medical issues and regular checks of the TSH to make sure we're actually managing to keep the TSH goal that we want, for that individual patient. And so that's my last slide. And I did see that there were lots of questions coming in. So we will try and answer your questions.
For those of you who joined late, my name is Maria Papaleontiou. I'm an adult endocrinologist at the University of Michigan. And I'm here with Dr. Jacqueline Jonklaas from Georgetown, who's also an adult endocrinologist. So is there anybody in the audience that has questions? Yes.
Question for the fetus. How important is it to up 30% early on in the pregnancy? What if you don't know that you're pregnant in the first trimester or whatever? How?
So this is a great question. And I can answer this, Jackie, sorry, let me move this so we can see you.
I need to be seen.
So it is truly important, so typically, so you're correct, right? Most women don't know they're pregnant until probably 6 to 8 weeks at least. And the increased thyroid hormone requirements for the fetus really occur in the first half of pregnancy. So the way I do it, for my patients who I know are trying to conceive, I tell them, when you find out you're pregnant, you tell your partner and then you call me. So I should be the second person you call. And I have them increase their dose preemptively by 30%, which is typically equivalent to 2 extra tablets a week. So I tell them take 2 tablets on Saturdays and Sundays. We will typically do this throughout the pregnancy. The baby's thyroid gland typically will start working around 12 to 13 weeks, but it doesn't make enough hormone to be sufficient until maybe 20 weeks. So definitely necessary for the first half of pregnancy. And then you're trying to also account for the weight gain that goes on during pregnancy. So very important. I usually do it preemptively. I don't know, Jackie, if you do the same thing. I know there's some people that check labs first, but I don't want to mess with that.
So I 100% agree. Patients usually know that they're planning a pregnancy, and I would tell them exactly the same thing. After you've told your partner, call me and we'll get some labs and we'll see where we are and, adjust from there.
Yeah. So, and typically I'll check labs every maybe 4 to 6 weeks in the first trimester, or in the first half of pregnancy. After that, you're supposed to check at least once a trimester, but of course it depends. So yeah, very important. So I can go down the list and then, so first question here, please address the issue of generic levothyroxine versus brand name Synthroid. I take the brand name, but the generic would be 40 times cheaper. So I hear you. And, I think part of this is cultural. So I think there's also certain institutions or certain providers that prefer one or the other, or I have patients who say, I feel better on one preparation or the other, and it's very subjective. As far as I know, the FDA has done their best to try to solve the bioequivalency issues that existed before they tightened their, recommendations. So I think it's okay to interchange between, as long as you monitor labs, soon after, to make sure there's no discrepancy. And you're right, cost could be an issue for some people. What do you think, Jackie?
Yeah, so I think the manufacture of these different preparations has been more rigorously monitored over the years. And I think some of the issues that we had, 20 years ago do not exist, and there's better regulation. So I think the difference between the different brands in terms of absorption is probably small, but it's real. So I think if someone knows they've been switched, I think it makes sense, particularly if they're not feeling well, to recheck.
Right. So I'll let you answer this, Jackie, but with combination therapy T4 and T3, what time of the day should we take the thyroid blood test? First thing in the morning without having taken any meds, or 6 hours after taking T3? I don't know that we know, but.
we don't know what to monitor if someone is on combination therapy. I would say probably the thing that, helps you is a trough level, before they take the labs. If someone goes to the lab, 4 hours after they took T3, the level will be high, but we also know it will drop down later during the day. So there really is no good time. I think when we do get one of the sustained release therapies that are, about to be tested, it'll be much easier, and it will be more like, sort of checking labs for levothyroxine. But right now, you could be very misled if a patient who's on a small dose of T3 goes to the lab a couple of hours later. You could be misled and have a normal TSH and a high, free T4.
I think that's the issue with it's hard to know what to recommend for patients to do because we don't know ourselves. How critical is the correct storage of levothyroxine? Does it need to be kept in the dark and in a cool place? Not always possible. So I think, again, you get probably the maximum potency if you follow the leaflet instructions. But, like I said before, we do understand that life happens. So do your best.
Agree.
So do dairy or calcium-rich foods affect levothyroxine absorption the same way as calcium supplements?
So I think they really do. You know, it doesn't really matter if the calcium is from a supplement or a food. You may get a little more kind of prolonged absorption of the calcium with a food. So maybe that would have a little bit of a less effect. But I would say if someone's having a very dairy rich, I don't know, yogurt or something, that's essentially like taking a calcium supplement. And you would have the same precautions. What do you think, Maria?
Yeah, so I agree. And typically the recommendation for these supplements is to take them at least 4 hours apart from your thyroid hormone. So, you know, for my patients with osteoporosis that do have to take calcium because they can't tolerate dairy or, you know, for whatever reason, I just tell them take, you know, if you take your levothyroxine in the morning, take a calcium tablet with your lunch and one with your dinner, or dinner and bedtime, to try to avoid that interaction. Is there any benefit to eating Brazil nuts for the selenium if you had a total thyroidectomy, but your TSH is still very high and your labs show you're clinically hypothyroid? So not to my knowledge, you know, I think at least the studies that have been done on selenium have not shown convincing benefit. So if your TSH is high, I would recommend you speak to your provider to adjust your dose.
Yeah, and I agree. The effect of selenium would really be on someone who has an intact thyroid gland. So if you've had thyroid surgery and you're taking exogenous thyroid hormone, there's no kind of mechanism that I could think of by which the selenium would help. And some of the data about selenium being beneficial, you know, with sort of thyroid inflammation really comes from studies that were done in areas of iodine deficiency. So there may be an interaction between selenium deficiency and iodine deficiency. But I think for someone who's taking thyroid hormone, I don't think you need to worry.
Yeah. I think the next two are similar. Does liothyronine need to be taken on an empty stomach like levothyroxine? Does it have absorption issues when taking calcium? Is fasting before or after taking recommended? And I don't know that we have enough data to recommend one way or another, but I would assume probably.
Yeah, I think liothyronine or T3, it's actually much better absorbed, and I don't quite know why, because the structural difference is minimal. But I think that old studies show it's got like 90% absorption as opposed to more like 75%, you know, for T4. So I can't quote much data, but I think it might be more forgiving, you know, in terms of absorption. But I think most people who would be taking T3 would probably be taking it at the same time as their first dose of T4. So, you know, I'm not sure that it makes a difference.
Right. Even though the subsequent doses are usually around meals or snacks.
Yeah,
so,
that's true.
But yeah. I don't advise my patients to fast necessarily before.
That would be too difficult.
Yeah. If you have an extreme intolerance to cold, could this be due to a low dose of levothyroxine, or is it unlikely to be unrelated autoimmune issue?
I can just make one comment. I'm not sure it's addressing it, but the symptoms of insufficient thyroid hormone are very non-specific. And so I'm just thinking of a patient of mine who had the most terrible cold sensitivity, and her thyroid hormone dose was perfect. And then she was found to have anemia and was treated for her anemia, and her cold sensitivity just went, you know. So there are very non-specific symptoms that sometimes it's hard to tell what it's due to.
Yeah, and similar to the question, I had also a patient who ended up having a different autoimmune disease, and some of her symptoms were explained by that. So, you know, I tell patients, at least, you know, if their goal is where it needs to be, but there's symptoms that we can't explain, you know, I think it's important to look. because we don't want to miss something serious that may, maybe a problem in the future. So the next one is, would being pre-osteoporosis, I'm assuming osteopenic, change your TSH goals? Even if you're an intermediate risk patient. So this is tricky. And this is where I think the personalized management comes into place. I think it depends kind of how soon is it after your diagnosis, how have you done over time? What Dr. Jonklaas talked about in terms of dynamic risk stratification, where we reassess at every visit. I tell patients things could change, right? You could continue to have excellent response, or we could see something in your neck that we're worried about, or your thyroglobulin could go up, so I think it's kind of a continuous conversation to have with that individual patient, and also kind of what action is being taken to take care of the osteopenia, on that front, or whatever else it may be, in terms of taking, adequate calcium and vitamin D, and making sure you're following up with bone density scans, etc.
Yeah. So if you had a person who had new osteopenia and wasn't exercising and had vitamin D deficiency and those things, you could certainly address those things, and then, follow the TSH and the bone density and see how to adjust.
So the next one is to you, Jackie. Do you know if there's any relationship between TSH suppression or hyperthyroid status and metabolic diseases?
So I think most of the data about metabolic syndrome is, associated with high TSHs. I don't really know of any data associated that shows a link between a low TSH and metabolic disease or syndrome. Maria, do you know of any?
No. But I think they're asking about TSH suppression, but yeah.
So not that I'm aware of. Yeah.
Right. I mean, we know there's an association with cardiovascular risk, but
right.
Why do doctors only change doses gradually, like 12 micrograms at a time, even if the TSH is 10 or crazy high? So I think this is also very individual. And, I guess I wouldn't put everybody in the same basket, because I don't change those by 12.5 usually. But I think maybe it's one of those things that you gain experience with the more thyroid cancer patients you see, and kind of get a feel of where the TSH would go for most patients, and how much to adjust. So I don't know how to answer this question. But again, I think communication is important. So, if you feel like, if your TSH is 30, and you're getting adjusted by half a tablet a week, is probably inappropriate. So I think just communicating is important. But I can't speak for anybody else. I can only speak for what I do. So.
Yeah, I mean, some of those tiny incremental dosage adjustments are used more when you've got an older patient, possibly with cardiac disease, who has had long-standing hypothyroidism, and you just don't know what the thyroid hormone will do to their sort of potentially cardiac ischemia, and then you might gradually increase the dose. But I think for most patients with thyroid cancer, we're not going to be making baby adjustments if their TSH is kind of out of the range.
I'm medullary, and so I had normal TISH and before. And so when somebody says, and I'm on a combination now, but somebody says, what are the symptoms? I don't know what the difference is. Can you say what kind of symptoms?
In terms of if you're over or under treated, is that your question?
Yeah.
Yeah. So, I'll make a comment to Jackie's presentation, which was more relevant for patients with differentiated thyroid cancer. So you're correct. For medullary thyroid cancer patients, there is no known benefit of maintaining TSH low. So we recommend TSH in the normal range. So typically, the most feared adverse effect, in my opinion, of over treatment is cardiac. So patients who are developing palpitations, for example, that they didn't have before, exercise intolerance, chest pains, those make me nervous. Some of the other adverse effects you won't necessarily feel, right? So like bone loss, you may not know that unless you have a bone density scan. And it's hard to know how much of that is postmenopausal, how much of that is genetic predisposition, how much of that, right, is related. So, I think going back to Jackie's point before, a lot of these symptoms are not specific, but the main thing I really care about is cardiac. So anything that may mimic a cardiac event. Jackie,
Agree.
do you have any comments?
Agree. I mean, the most feared thing is atrial fibrillation, which can occur even in young people who are over replaced. And so if someone's got, an irregular heartbeat and shortness of breath, that is something that we would respond quickly to.
And then I've seen it on the other spectrum where people are undertreated and they have high TSH. I had a patient with heart failure in the hospital, for example, older gentleman. So it can go both ways. So I think, again, if you feel something's not right, check. Yeah. Yes.
And is that the T3, the T4 or the T3?
So typically we would check a TS. Oh, you mean that's doing it?
Yeah.
Yeah, that's a good question. In combination therapy, I don't know. Yeah, I mean, typically a high T3 is a more potent suppressor of TSH, but it depends on what dose you're on and what the ratio is. So yeah, I don't know. But yeah, it's a good question. As you can see, there's a lot we don't know, but yes.
Does having a elevated thyroglobulin level interact with your TSH level, or does it make your blood test results not reliable?
Jackie, do you want me to repeat, or did you hear?
Yeah, no, I heard the question. Maybe I can have a first pass at it. Sure. So in general, the higher someone's TSH, there'll be a little bit of a response in terms of the thyroglobulin increasing. And so as you lower the TSH, the thyroglobulin should go down a little bit. And so there is a relationship, between the two. And so if someone had a TSH of 1 and a particular thyroglobulin, and the next time their TSH is 0 and the thyroglobulin has gone down, nothing really may have changed, but the thyroglobulin has responded to the TSH.
Right. The thing that could interfere is thyroglobulin antibodies. So typically, at least at the University of Michigan, we reflexively will check both thyroglobulin and thyroglobulin antibodies because approximately 20 to 25% of thyroid cancer patients have antibodies to the thyroglobulin, and that could make your thyroglobulin level unreliable or falsely, it could give you a false sense of security. So that's one thing that I always check with the thyroglobulin. So from online, is it common for someone to experience extreme fatigue a week after starting either levothyroxine or desiccated thyroid extract? My 24-year-old daughter experienced this even with minimal starting dose and had to abandon trying them. She has half a thyroid and is on selpercatinib for medullary thyroid cancer. Her lab showed increased free T4, but her free T3 remained at the extreme low end of the normal range. So the extreme fatigue, so a week after starting thyroid hormone is too soon to really make any conclusions. It takes at least 6 weeks for steady levels to be reached. So it could be that she wasn't adequately replaced so early enough. So I'm not sure. So her lab showed increased free T4. I'm assuming that was on medication.
I mean, some of those types of drugs can interfere with T4 to T3 conversion. And so, it might be, sometimes people have used T3 therapy in individuals who are on those types of medications. I think it would involve looking at the entire thyroid panel and the specifics of the drug that was being used.
Sorry.
Oh, so it looks like we're out of time, but both of us are really happy to answer questions. So I can, I'm happy to provide my email. I think Gary Bloom has our contact. So I'm happy to answer questions. Sorry, we ran out of time, but thank you for your engagement.
Yeah, no, thank you, everyone. Those questions were all absolutely wonderful questions, very, very important questions.